I fractured an instrument in unexpected tooth, and I cut it in half. And I found this. As you can see, if you divide the broken instrument into 3 sections, the epical 1/3, and the middle 1/3, and the chrono 1/3. If you take a look at the epical and the middle 1/3, there is no denting wall holding the broken instrument. In other words, there is no denting walls touching the broken instrument. However, if you look at the chrono 1/3, you see denting wall touching the broken instrument. So if you just remove tiny denting wall on the inner wall, you can free the broken instrument. So this is how you prepare the root canal for broken heart removal. Very important. This extracted tooth with a broken instrument tells you how to remove the broken instrument, how to prepare the canal for broken heart removal. And somebody accidentally broke an instrument in the training, hands-on workshop. And I took a close look at the broken instrument. If you see the epical portion, you see the space from here to here. But if you look at, this is the chrono end of the broken instrument. If you look at the chrono end, you see there is no space. No space. So if you create the space on the inner wall, you can free the broken instrument. And also this study shows highest stress concentration on the chrono end. You see the highest stress concentration. Some insect is flying around me. And if you see the red area here, the red area represents highest stress concentration. So you see the highest stress concentration on the outer wall compared to the inner wall. So that's why if you touch the outer wall, you will break it with orthotics. Okay? That's why you stay on the inner wall so you can prevent the secondary fracture. There is another reason why you create a space on the inner wall. Because if you push the instrument from the outer wall, the broken instrument will go down in an apical direction, right? But if you push it from the inner wall, the instrument will go up. Okay? So let me quickly show you how it happens. So this is a broken instrument inside a plastic block. I'm pushing the instrument from the outer wall. I don't hear the sound, but anyway. Can I have sound? Maybe not. Okay. So as you can see the instrument dancing, right? Dancing, but there is no removing the instrument. But as soon as I press the tip on the inner wall, this is the inner wall, instrument immediately came out. There is a big difference between how you press the instrument.
شلون ترك حلوة؟
Or how you, the difference between when you press the tip on the outer wall and on the inner wall. There is a big difference. Always activate orthosonics from the inner wall so you can remove the instrument. So what kind of instrument is harder or more difficult to loosen in preparation? According to the Hapasaro group, the majority of small size or multi-synthetic phase instruments are more susceptible to deformation, which makes it more resistant to fracture because they release stress by being deformed. When they break, they are also easy to remove as they don't bind to canal walls. However, the large size or austenite phase instrument fracture due to cyclic fatigue. So they require more time to remove as they bind to canal walls. So in conclusion, most of the rotary instrument fracture because of cyclic fatigue, whereas 91% of nicotine hand instrument fracture due to torsional fatigue. If something broke because of torsional fatigue, it always engaged to the canal walls. That makes more difficult to remove. So there are two conditions, dry or wet, in preparation and also removal attempt. As I told you, there are two parts, preparation for broken for removal and removal attempt. In preparation, you have to be in a dry condition because you have to see it. Okay? But in a dry condition, you have to be careful of heat generation. If you have higher temperature inside the root canal, you can damage the PDA or you can break the fire at higher temperature compared to lower temperature. But once you saw the instrument dancing, you can move on to the removal attempt. In a removal attempt, you can be in a wet condition because you can take advantage of cavitation or acoustic cleaning. You can take advantage of these in a wet condition. That's why when the preparation is completed, you can put EDTA or maybe soybean oil. So you can have advantage of cavitation or acoustic treatment. And what type of fluid is good for instrument retrieval? I just want to tell you, low viscosity and low surface tension increases the ability of the fluid to penetrate into small anatomical spaces, such as a small root canal or beyond the curvature. So liquid having low viscosity tends to spread with greater ease in the root canal. So it's better to have fluid with low viscosity when it comes to loosening the broken instrument. So this is the table showing viscosity at 20 degrees. So I just recommend soybean oil because soybean oil has medium viscosity. So you can create mechanical strength when you use ultrasonics in the presence of soybean oil. But if you use like EDTA or maybe alcohol, which has a lower viscosity than water,
البناءات المتوفرات في الاي دي تي اي والالكحول نظموا في شيء صعب تحصل يعني.
with ultrasonics. But in a straight canal, you can remove the instrument in the presence of water or EDTA. Sometimes EDTA is good because you can create dentin debris and EDTA removes dentin debris. So it's good. So this is my recommendation. Medical grade silicone oil. When do you use it? You can use this to loosen the broken instrument because silicone oil has a low viscosity and low surface tension and excellent lubricity. That's why in order to loosen the broken instrument in a shorter time, I recommend you use silicone oil in the preparation stage. So let me quickly show you a video to see the difference between EDTA and soybean oil. So this is EDTA. You see the broken instrument around the curvature, more than 30 degrees. I'm activating ultrasonics, but the broken instrument stayed in the same place. Then I will try I will try soybean oil. So I'm replacing the EDTA with soybean oil. Then I will activate ultrasonics. This time, you see the instrument is coming out. There's a big difference. So whenever the temperature is more than 30 degrees, I recommend you use soybean oil. If the temperature is less than 30 degrees, you can use whatever you like EDTA, even water or alcohol. So this is my recommendation. Okay? So always measure the temperature with CBCT. And also, the study shows the depth of ultrasonic activated fluid increases with increasing power setting to remove denting and purple debris equal to the ultrasonic tape. So if you increase the power when activating ultrasonics, you can create turbulence equal to your ultrasonic tape. So when you make removal attempt, just increase the power setting by 20%. And if the broken instrument removal procedure exceeds 45 minutes, you should give up on the removal attempt because you are already tired. If you are tired, your mentality is not good enough. So forget about removing the instrument. So now I have to show you key preparation technique based on those studies. So this is what you use to make a preparation and also to make removal attempt. So many people in Europe ask me the same question. So what's wrong with using ET25? It's good, but if you take a close look at ET25, it has a diameter of 0.3 millimeter with a 3% taper. This is too much compared to the TFRKS. Okay, this is too much because TFRKS has a diameter of 0.1 millimeter with 1% taper. This is very conservative. You can be minimally invasive using the TFRK, or you can just sharpen the tip, or you can just reduce the diameter of ET25. Then you can be the same. You can be conservative in denting removal. Why? Because if you try to place your ultrasonic tip, ET25 or CPR8, whatever you use, you will end up pushing the broken instrument into an apical direction. Because before you getting into the space on the inner wall, you push the instrument because of the big diameter or big taper. But if you use a small diameter tape with a less taper, like 1%, you will get into the space without pushing the broken instrument in an apical direction. This is what you expect to happen. That's why always sharpen the ultrasonic tape. Always sharpen the ultrasonic tape with a brownie. Yesterday and today we have a workshop. I told the participants how to sharpen the tape. So they already know how to sharpen the tape. So anyway, this is the procedure to prepare the canal for broken file removal. Always start with enlarging the canal with a number 3 GG bar if the curvature is less than 15 degrees. If it's more than 15 degrees, don't use number 3 GG bar. Of course, you can use the number 3 GG bar for the straight portion. But if you are enlarging the curved canal, use number 64 high-flex EDN. This is my favorite. It's a multi-seating creative instrument. It's flexible. It has no restoring force. So that's why I prefer to use this instrument when the curvature is more than 50 degrees. Then after that, you create space on the inner wall about 1/3 of the broken file length. For example, if the broken instrument is 3 millimeters, you can just create 1 millimeter space on the inner wall. Then you will see the instrument dancing. However, when the curvature is more than 30 degrees, and if the broken instrument is austenitic nickel titanium instrument, maybe you need to extend the space more epically, maybe halfway, in order to loosen the broken instrument, in order to make the broken instrument dance. And you also need a drop of silicone oil to help you loosen the broken instrument. This is what I do all the time. I always measure the instrument, I measure the curvature, then I know what to do with the instrument. So start with a straight ultrasonic tape to create 90-degree semi-circular space. Then you will switch to a straight ultrasonic tape to extend the space to 180 degrees. If you have 180-degree semi-circular space on the inner wall, you will see the instrument dancing. But as soon as you see the instrument dancing, you are finished with the preparation. You don't always have to complete the 180-degree semi-circular space. As soon as you see the instrument dancing, you're finished. Go to the removal tent. Many people ask me the same question. What is the difference between the broken instrument dancing and flexing? If you see the instrument going from the original place to another place, that's dancing. But if you see the broken instrument going from the original place to another place and coming back to the original place, that's flexing. If you see the instrument flexing, you are not finished with the preparation. Continue with the preparation until you see the instrument dancing. You must see the instrument dancing, not flexing. Flexing is not good enough. Very important. So now let me talk about key predictable removal attempt. So this is how you decide on the technique for removal attempt. If the broken instrument is less than 3 millimeters, you can just use ultrasonics. If the broken instrument is between 3.1 millimeters and 4.4 millimeters and visible and the curvature less than 30 degrees, you can use ultrasonics. But when the curvature with the same condition, more than 30 degrees, don't use ultrasonics. Use non-ultrasonic technique. If the broken instrument is more than 4.5 millimeters, you should not use ultrasonics. Use non-ultrasonics, including the loop or the DXP and the shaper. If the size of the broken instrument is more than 80, longer than 3.5 millimeters, use ultrasonics in the presence of oil or the loop or maybe the DXP and the shaper. Something like this. Maybe I can talk about non-vivid situations, but it will take lots of time. So I stop here because I do not want to confuse you talking about removal of non-vivid instrument. So I just stop here. So after you saw the instrument dancing, simply place your ultrasonic tip in the presence of EDTA when the curvature is less than 30 degrees, or maybe you can use soybean oil when the curvature is more than 30 degrees. And activate your ultrasonics in the space you created. Use a small up and down motion within the space created on the inner wall. Then instrument should come out in a few seconds. Okay? So again, if it's more than 30 degrees, use soybean oil. But if it's less than 30 degrees, use EDTA. This is how you decide when removing the instrument with ultrasonics. But remember this is also another important tip that I'm going to give you. If the space here between the outer wall also and the ultrasonic tape is smaller than the broken instrument, the broken instrument will not come out because it will end up hitting the space between the outer wall and your tape. But if it's wider than the broken instrument, it will come out through this space. So make sure you have the space larger than the broken instrument. In addition, you must have fluid, EDTA or soybean oil in the pulp chamber. If you have only EDTA inside the root canal, it will fluctuate within the root canal. It will not come out from the root canal. In order to make the instrument jump out of the root canal, you must have water in the pulp chamber. Very important. Okay? So I want to show you many cases, but I don't think I have time to show everything. So, or if you have stroke of irrigator, actually nobody knew about stroke of irrigator in the hands-on workshop I did yesterday and today. This is just a irrigator, or this is just a small diameter syringe. Okay, you can blow air with this stroke irrigator, and when the instrument is already dancing, you can blow air into the root canal to remove the broken instrument, because the root canal is already closed, so you don't have to worry about air going into the peripheral tissues. There is no way you get air into the peripheral tissues. So let me quickly show you. So I'm going to blow air. Now the instrument came out. This is how you remove the instrument. And also, what about the double curvature? When the broken instrument is here around the curve, this side is considered inside. However, if you have a broken instrument around the second curvature, this side is considered inside. Very important. So this makes a big difference. So like this, you see, this is a difficult case. I do not want to confuse you, but I want to show you this case. So this is impossible or possible? This is still possible. If you can place your ultrasonic tip into the space on the inner wall. Don't get wrong, okay? This side is inside because the broken instrument is around the second part. So this side is inside. So I place my ultrasonic tip on the inner wall. One came out. There are two instruments here. And the second one came out. This is the radiograph I took after I removed two of the instruments. Then I negotiated the root canal. I had a epical patency with a double curvature canal. So this is what happened. Okay, now I want to talk about MT oxidation. But before that, I want to show you more cases. So, if the broken instrument is actually outside the root canal, like this, is it possible or impossible to remove? Actually, if the broken instrument is outside the root canal, nothing is holding the broken instrument. It's just floating inside the space. So in this kind of case, when the instrument is smaller than 3 millimeters, it's not difficult. You can just activate ultrasonics in the presence of saline. Okay? Then you create turbulence equal to your ultrasonic tip. Then the broken instrument come out from the epical tissues. So I did many studies on this. So broken instrument is actually outside. I'm going to activate ultrasonics, use up and down motion, then you see the instrument is coming out like this. Here. This is what you expect to happen. So here, do you see the instrument outside root? I did exactly the same technique. The instrument came out, and this is the poster. Or you can use the XP finisher with the XP finisher spinning at 2500 RPM in the presence of saline. You create turbulence. Okay? Then you can remove the instrument. You see, broken instrument outside root canal. I use the XP finisher. The instrument coming back into the root canal is inside the root canal here. It's out, and this is a post-op LTA obturation. I have so many cases like this, but I don't have time to show you everything because I want to talk about MTA obturation. So now let me talk about MTA obturation. Why people ask me the same question? Why you don't use gallbladder? There is a reason. Because gallbladder does not want to denting. MTA does. And patients experience less frequency of short-term post-obturation pain after single visit than those having multiple visit root canal treatment. This means if you finish your treatment in one visit, but compared to the multiple visit using calcium hydroxide as an intracanal medicament, you have more post-operative pain, which is not good. So I always try to finish the case in one visit. And according to this study, they concluded from a microbiological point of view, treatment of teeth with apical periodontitis performed in 2 appointments was not more effective than a single visit procedure. So that's why I want to finish the treatment in 1 visit. Single visit root canal treatment was safer in terms of endodontic flare-ups compared to multiple visit root canal treatment. So single visit root canal treatment was safer in both vital and non-vital cases. Okay? If you compare the 2 preparation techniques for LTA obturation or gallbladder obturation. If you look at the gallbladder obturation here, you need more taper when doing vertical compaction. Working length must be accurate because you do not overextend the gallbladder form. You will have more incidence of ledge formation around the curve because of the taper you must create. More incidence of instrument fracture, more incidence of vertical root fracture, more denting will be sacrificed if you are preparing the canal for gallbladder root fillings. If you look at the preparation for MTA obturation, it's completely opposite. If you compare the properties of MTA to gallbladder properties, gallbladder shrinks 7%. And it depends on the sealing ability of the closon restoration. Gallbladder is always susceptible to bacterial ingress, and biofilms form on gallbladder fillings, but the biofilms will be eliminated with MTA. And there is no bonding between gallbladder and dentin. Gallbladder is much easier to remove. That means gallbladder does not bond to dentin. If you look at the properties of MTA, everything is opposite. So that's why there are many reasons why you should use MTA. Why do you have to use gallbladder? It's nothing. there's no advantage over the use of MTA as a root feeding material. So look at this case. I used to use garapacha and the serum. This is one of the cases where I use garapacha and the serum, but the lesion didn't disappear. So what I did was I replaced garapacha fittings with MTA, and this is immediately after MTA operation. And this is 3 months, 9 months, 12 months, 24 months. You see nice periodical healing with MTA. This difference between this condition and this condition is the material used for obturation. And if you look at this study, this is a plastic study. If you look at the outcomes of endodontic treatment are more favorable when the tooth is overfilled than underfilled. However, the outcomes of endodontic retreatment are more favorable when the tooth is underfilled than overfilled. Why is that? Because you could push bacteria beyond epicoforamen, and also biofilms grow on the garapacha fillings. That's why, especially in retreatment, you should not use garapacha because biofilm always grows. So this is one of the reasons why I don't want to use the garapacha in retreatment. So look at this. This is a preoperative radiograph. You see the lesion, periodical lesion. This is a sagittal view of CBCT. You see a big lesion. However, you see the root fins with garapacha and the serum. It's not overextended. It's not underfilled. It looks good. However, you have periodical lesion. This is not good. So for this case, what I did was very simple. I replaced the garapacha fillings with MTA. That's all I did for this case. So I removed the garapacha. I use XP endo finisher in the presence of chloroform. Then this is immediate post-op radiograph showing nice MTA obturation. It's a little bit overextended. I always extrude MTA on purpose. And this is 3 months post-op, already showing nice periodical healing. The difference between this condition and this condition is the material used as a obturating for obturation. So now let me talk about MTA obturation. So again, let me summarize the properties of MTA. So MTA provides high sealability, okay? Because MTA produces high velocity apatite layer between the dentin and MTA. That's why you have an excellent seal between the two. And the particle size of MTA is very small, smaller than the dentinal tubules. It's only half microns to 3 microns. But the size of the dentinal tubule is 2 and 5 microns. And MTA is bioactive. MTA promotes cementogenesis, odontogenesis, osteogenesis, and PDL reformation. Garapacha doesn't have any of these. And MTA is hydraulic. That's why even the canal is wet, it doesn't matter. It will set. And MTA kills bacteria, bactericidal, but garapacha doesn't. MTA is completely biocompatible. That's why even the MTA is extruded beyond the apical foramen, nothing will happen. There are many reasons why you should use MTA as a good filling material. So So when you mix MTA with water, water should be replaced with phosphate buffered saline. Why? Because there are studies showing MTA mixed with PBS. PBS means phosphate buffered saline, promotes crystallization and bacterial endowment, leading to elimination of bacterial biofilms. So, for example, here you see many bacteria in the dentinal tubules. After a few weeks, you see crystallization inside the dentinal tubules. All the bacteria which were present before the treatment all died. And in addition, you will have hydroxyapatite layer between dentin and MTA. Because of this, you have an excellent seal. Do you have to remove smear layer before obturating the canal? The answer is no. You don't have to. Even you remove the smear layer, it still has an excellent seal because of hydroxyapatite layer. So he did the study, and the conclusion was, if you didn't remove the smear layer using EDTA, here, So EDTA is not necessary for better sealing. So as you can see, this is MTA with smear layer. So this is much better than the MTA obturation without a smear layer. So if you have smear layer, you have more bonding, more sealability. So try not to use EDTA. So I scratch the canal walls when compacting MTA with my file. So you can create smear layer while compacting MTA. This is my strategy. And this is a 7-year post-op. This is 8-year post-op. There is no difference, no gap, 0 micron between MTA and dentin. Okay? You see the chemical bonding. So try not to remove smear layer. You don't have to. And there are 2 types of MTA. The original one, Pro-root MTA. But if you compare the gray MTA and white MTA, MTA is better. Gray MTA appears to be a better sealing agent than white MTA if it's challenged by human saliva. This is what happened. But if you look at the Garapacha fillings, they all allow leakage. So there's no reason why you have to use Garapacha. Why do you have to overturate the canal with Garapacha? Garapacha allows bacterial leakage. Nothing good about using Garapacha as a root filling material. Oh, the light is bad. Okay?
ما عندكم باليابان اكو شيء احنا عندنا هو ما عندنا صحيح.
Okay, if you use MTA, there are 2 advantages, 2 main advantages using MTA. During hydration forms calcium hydroxide. So you can have calcium hydroxide if you put MTA inside. And calcium hydroxide produces a high alkaline pH. High alkaline pH. And MTA is, anti-inflammatory. MTA releases slow releases of calcium ions during hydration. And MTA induces, as I told you, MTA is bioactive, so that's why MTA induces progenitor cell migration and differentiation. So MTA is bioactive, MTA kills bacteria. Very good. is all I want for retreatment. And this study shows that higher concentration of antibiotics have a detrimental effect on stem cells. Okay? But lower concentration and calcium hydroxide are conductive with stem cell survival and proliferation. So this is another reason why you should use MTA, because MTA is bioactive. But gallbladder doesn't carry any bioactive effects. And pH value of MTA is 10.2 immediately after mixing, and it will rise up to 12.5 and remain constant after 3 hours. And MTA reportedly kept its high pH value throughout the course of a long-term study performed over 2 months. So MTA maintained high pH. That's why even after ovulating the root canal with MTA, it keeps killing bacteria, eliminating the bacteria, or eliminating the biofilms. And MTA is biocompatible, that's why you will see osteoblast cells proliferating on MTA. But if you use amalgam, if you use IRM, osteoblast cells all died except the MTA. So that's why MTA is biocompatible. Don't worry about extrusion. If you extrude MTA, what will happen is you have hard tissue deformation or hard tissue formation directly on MTA. This is cementum. So it's okay. You can extrude MTA. You can purposely extrude MTA to get more hard tissue formation. So when MTA is used as an obturation material, it not only induces closure of the main canal by new cementum deposition, but foramina of accessory canals sealed by new cementum synthesis is a common finding in canine models. So this means if you obturate the main canal, you have cementum. But if you look at the lateral canals or apical ramifications, the tissues will be replaced with cementum. So this is my case. I found the lateral canal here. And you see lateral region. I was not successful in getting MTA into the small anatomical space here. But even I didn't get MTA into the space, you see the healing because of the high pH and maybe cementum inside the root canal. So it will create alkaline environment. Even the MTA is not in there. And they compared two MTAs. One is product MTA and the other one is bioceramics. But MTA is better than bioceramics when it comes to bone regeneration. So if you have a big lesion, I suggest you use product MTA. But when it comes to regenerative endodontic therapy, including vital pulse therapy, biodentin or bioceramics is much better than product MTA. It will induce more odontoblast proliferation compared to product MTA. But when it comes to osteoblast cell proliferation, product MTA is much better. So that's why I use product MTA as a good filling materials. And also, MTA shows anti-inflammatory effect. So when the patient comes into your office in a big pain, try to finish the case in 1 minute using MTA. And maybe next few hours, the pain will disappear from your patient. This is another study telling the same. So, how do you obturate the canal? So this is a procedure to obturate the root canal with MTA. You can minimally instrument the root canal. Usually, you can use nickel titanium instrument with 4% taper. You don't have to, taper the root canal because you don't apply vertical compaction. You can just, because MTA is like a sand. This is like cement. You don't need vertical or lateral condensation. Just you can push it. Push it into a small anatomical spaces. So finish your instrumentation. Remember the epical size. And you pick up the instrument one side or two sizes smaller than epical diameter. For example, if your preparation is completed with number 4004 instrument, then you pick up number 3504 instrument to be used as a drugger. Okay? So this is how you choose the instrument as a drugger. Then you can just rotate the funnel counterclockwise to push the MTA into an epical direction. And then you can use up and down motion to spread MTA into small anatomical spaces. What is this black area? Okay, it's gone. So this is how you mix MTA, how you carry MTA and put it in the root canal. I mix MTA with PBS, phosphate buffered saline, on a glass slab. Like this, and this is a new device to compact MTA. So let me quickly show you how you do this in the video. So just you need a few drops of PBS, phosphate buffered saline. You mix it like this. The consistency of MTA is like a yogurt. So I can almost eat it. It looks like a yogurt. Then you can carry MTA with a plumber, or this is a MTA carrier from woodpecker, and take it into the root canal and push it like this. Then here comes the plugger. You can push it into an epical level, into the epical one part. Then you can use the file, rotary file, and rotate the file counterclockwise.
مبدأ اللانتولو يعني. نفس مبدأ اللانتولو.
And this is a new one. This is a prototype.
thick.
And the setting for obturating the root canal is
أنا قصدي كمبدأ إنه يوزع.
you use watch winding motion at 150 RPM. Then you can rotate the file counterclockwise at 100 RPM by pushing this here. On the right, you can activate rotation. On the left, you can activate sonics. So with sonics activation, you can condense MTA really good. So mix MTA with BBS and carry the mixed MTA into the root canal with a plugger, Then push MTA with the instrument that you picked up, rotate the file counterclockwise using a small up and down motion. Then apply sonics or orthosonics so you can get MTA into small anatomical spaces. So this is how you do this, how you obturate the canal. Okay, this is how you observe canal. Mix MTA with PBS and put it inside with a plugger like this. Then this is the setting. 90-degree watch winding motion and clockwise rotation like this. So this is watch winding motion. 90-degree watch winding motion. When you want to carry MTA into the epical one tab, I use this rotation, watch winding. Then you can rotate the file counterclockwise at 100 RPM. You see the accumulation of MTA here. Then you put more MTA and condense more. And you do the same. Here comes the instrument. One side smaller than the apical diameter. Watch winding. Then counterclockwise rotation. Use small up and down motion. Then activate orthosonics. Then you see the lateral canal was immediately filled with MTA. This is sonic activation. So you see the path from the lateral canal. You see here also there are two lateral canals. One is in the epical one tab, the second one is in the middle one tab. You see more paths, more MTA coming from the lateral canal in the epical one tab, and more coming out from the second lateral canal. So this way, you can compact MTA really good. Then you can use plugger to condense MTA. If you are planning to place a post, like a fiber post, then leave some space for the placement of the post. Then you place with cotton pellet inside the root canal. Then close the cavity with cabbage. Okay? So there is no void. So this way, in the treatment, you can be more successful. So I will show you some cases from my practice. So look at this big region. You see the big region here and here. I overlaid canals with MTA, the same technique I showed you previously. And this is 10 months also showing nice periodical healing compared to this and this. Look, you can see the lamina dura completely deformed on the roots. And this is 60 months post-op showing the same nice condition. Another case, there is no border between the oral cavity and the sinus. But I intentionally extruded MTA. This is immediate post-op radiograph showing MTA obturation extruded beyond the apical foramen. And this is what happened 6 months after MTA obturation. You see bone completely deformed in the defect here. Look at this. Look at the bone. You see the vertical fracture. You see the big big horizontal fracture. What I did in this case, because look at the position of the horizontal fracture, it's below the crest of bone. So there is no way you can infect the spaces here. So what I did was very simple. I pushed MTA into those defects here, and this is the 3 months post-op. You see defect was mineralized, maybe cemental. And this is the 6 months post-op, and this is the 2 years post-op.
Diyorlar.
And this tooth supports denture. There's no mobility of the tooth. Another case, big one, here and here, I induced bleeding on purpose because I want healing, rapid healing. And this is 5 months post-op compared to the pre-op radiograph and the CBCT images. You see nice bone deformation. You see there's no bone on the distal aspect, but you see the completely bone filled in the defect. I have lots of cases, but anyway, I think I have 10 minutes, 5 minutes, maybe. Okay, maybe 5 or 10 minutes. Okay. So another case, you see the big periapical lesion because of the perforation on the palatal aspect of the root. So I removed the carapace because carapace does not seal the perforation site. So what I did was very simple. I filled the space, including the perforation, with MTA. This is 18 months post-op showing nice periapical healing. You see the bone was completely deformed in those defects. Here, if you compare this image with this, you see nice bone deformation. So, incidence of external apical root resorption associated with apical periodontitis. This means whenever you see periapical lesion, you may have external apical root resorption, about 80%. So, in majority of the cases with apical periodontitis, you have external apical root resorption. And if you have external apical root resorption, you may have biofilms in those defects. So, in order to remove biofilms outside the root, you should use MTA because MTA can eliminate biofilms. So, if you look at this is bioceramics, premixed MTA, this is gray MTA, this is white MTA. After 24 hours, you can eliminate 77% of biofilms with white MTA. This is the difference. If you want to use premixed MTA, the killing rate or removing rate of biofilms will be reduced over time. However, if you mix MTA with water, bactericidal effect will increase over time. So that's why I want to mix MTA with DBS. I know bactericidal effect will increase over time. This is the reason why I do not want to use pre-mixed MTA, syringeable MTA. So in this kind of case, this is a study from done by Italian dentist, Dr. Domenico Ricucci. You see external root resorption here because of the periapical periodontitis. And he found biofilms between the carapace and dentin. So in this kind of case, you should extrude MTA on purpose to cover those defects, external root resorption. This way, you can eliminate biofilms without doing surgery. So this is how you retreat the tooth with pre-operative apical periodontitis. So you instrument the canal, you remove the carapace fillings, you clean and shave the root canal, maybe you can use ultrasonic irrigation, or maybe you can use laser irrigation to remove infection from small anatomical spaces, such as an isthmus, or lateral canal, or the apical bifurcations. Then you can actually overturn the canals with MTA with over extension to cover the apical root resorption. So like this, you see a big defect. What I did was, instead of doing the root and surgery, I filled the defect with MTA. And this is 12 months post-op showing nice tissue deformation. This is another case. You see a big defect. You see the external root resorption. I intentionally extruded MTA. This is 18 months post-op showing nice periodical healing. Actually, the resorption was gone. You see the round, it looks round. It looks like a convex concavity. Another case, you see a big periodical region, and what I did was I extruded MTA intentionally, and this is 10 months post-op showing nice periodical healing. I guess you have seen enough cases. So I'm going to finish the case. Thank you very much for your attendance, and